Good afternoon, everyone. I see people joining in now. Welcome to today's live Q&A. We're bringing back somebody that we've had in the past. Before I bring her on and introduce her, I just want to say thank you to everybody that tunes in every week as we talk with individuals around the state and the country about just things that are going on right now in recovery and just in your community, and just bringing conversation and dialogue and communication to those to stay connected during this time. This is a time for you to also engage in conversation with us and with our guests, so feel free to put in comments down below, and also we will have some time towards the end for you guys to ask questions for our guests. Today, we do have somebody in the past, Dr. Doniere, so she's going to be on with us today. For those of you that don't know me, I'm Wes Van Epps with Wisconsin Voices for Recovery, and I'm also joined today by my coworker Jessica Geschke. So we're going to be bringing Julie on here in just a second, just to talk a little bit about what's been going on in the eyes and the perspective of the emergency department. With COVID-19, and Julie's going to bring up some good topics and good discussion around how they've been dealing with COVID-19 in their emergency room, and any questions that you guys have around that, feel free to ask. You can also, throughout this, raise your hand if you have a question that you want to ask Julie. We can then unmute you and go from there. So I'm going to bring Julie on now. Julie, welcome with us here today. I know that you were on, our first Q&A back on April 1st is the first one that we had. And we're so blessed to have you, somebody that we know in the field that you're in, to also ask questions too about what's going on, and for you to come on here with us and just to give information to the public around this topic, since it's obviously still a hot topic within our nation. And people just want to hear, facts and what's going on. So welcome, Julie. If you can, just give us a little, before we get started, give us a little background about who you are, possibly, the career path that you chose, some of your experience in your career. I know that you are an emergency medicine specialist, and you have been for about 24 years. But you're also too on the topic of the ED2 recovery. So you're a part of the ED2 recovery program, you in the emergency rooms that you work in. And you've been a part of that program since October of 2018, and that's how we got to know you. So yeah, just give us a little bit about who you are, and then we'll get into the topics for today.
Thanks, Wes, and thanks for having me, you guys. First of all, I'm just an ER doc. I'm not an epidemiologist. I'm just an ER doc, and I serve primarily in Milwaukee County. I work at St. Joe, St. Francis, Franklin, and at All Saints and Racine and Elmbrook. So we're in a little bit of Waukesha and down in Racine. And I've been doing that for a long time, and got involved with, got interested in opiate use disorder, and just went to a meeting a couple years ago and heard Jessica speak. And she inspired me about her ED2 recovery. I'm like, I need to talk to her. And so we ended up applying for and getting the grant. And so we've had recovery coaches in our ER for the last year and a half. And it's been awesome. So loved having the recovery coaches in our ER. It's been a benefit to our patients primarily, but it's been really a benefit to decrease stigma within my group, the nurses that I work with, working side by side with the recovery coaches who come in and forged beautiful relationships has been very beneficial to my partners also. So thanks for having me.
Yeah, and we're excited to have you, Julie. I know that you and your emergency room staff have done such great work in the ED2 program with the collaborating partner in your community of WisHope to bring those recovery coaches in your ER. I know that with that program specifically, you've been kind of the front runner for that program. And I before my work here with Wisconsin Voices, I know that you've put in a lot of work, and we've worked together a lot to get that program going. And I know that without your hard work and dedication, I don't think it would be as much as it would be today. So I appreciate the work that you've put in. But yeah, jumping into kind of today's topics, we're going to kind of circle back a little bit later about some more questions around the ED2 program. But To start us off here, I think we just want to know a little bit about COVID and how your ER system specifically has been dealing with COVID since we've last talked, beginning of April. So that was kind of when the pandemic was really started, and people were getting informed about it and what to do and what protocols to take. So looking back at that up until now, what are some information or what are some things that your ER has done since then, and how you guys have been dealing with COVID?
Well, March 13th was our initial, within my system, was our initial positive case, and it was my case. And a lot of things have changed since then. I think the last time we spoke in April, we had seen a pretty significant decrease in our census, which is a little bit counterintuitive, because you think we have a huge pandemic, why are numbers going down? But while our COVID numbers were really exploding in St. Joe's specifically, which is in northern Milwaukee, had the biggest, we were the epicenter initially. So we saw a ton of COVID cases, but people appropriately were social distancing and not coming in. So our census across the board for patients coming in to be evaluated for all illnesses went down about 50% across the board in April. Our numbers are rebounding slowly. It's been interesting because in the last few months, I've seen more ruptured appendicitis, more heart attacks that happened 2 days ago, more strokes that have completed than I have in the course of my career. So a lot of people are not coming to the ER, and a lot of people are not coming to the ER for their substance abuse and their mental health problems also. So how we've dealt with that, number one is we're trying to get the message out that the ER is safe. Please come to see us for whatever emergencies you have, including substance abuse and mental health issues. We really want people to know that it is a safe place. All of our facilities and and I think I can speak to all the ERs in the country because we're both all kind of doing the same thing. We are identifying people as having the possibility of having COVID at the door. So we can keep that patient population separate physically from people who don't have COVID complaints. Now, and also that being said, everyone's masked in the ER. Everything's clean between each patient. We're doing everything to decrease the spread. So we are really encouraging people for emergencies, come back, we're here for you. And that really, really accounts for substance abuse and mental health issues, because those numbers went down dramatically also. But in the last month, I've seen more than usual overdoses and more than usual suicide attempts. This is an uncertain time, and it's affecting everyone. And those with underlying mental health issues and substance abuse issues, wow, it just adds on to everything else they're dealing with. So please know all ERs are open for business and there for you in your crisis, whatever it is. Did that answer your question, Russ?
Yeah, and I think too, I guess out of that, I have a question. You mentioned that just the overall, I guess, emergency room visits of things that you would typically see in the past have decreased. You brought up a couple examples, but when those individuals, say they do come in, do you guys ask specifically on why it's taken them maybe a day or two to come into the ER rather than in that time of possibly emergency room care, they don't initially go into the emergency room? Is it because of the fear of COVID right now, or?
Oh, I think it's definitely the fear of COVID. And I don't ask a lot because I only have one shot to make people trust me. So I only have one patient interaction. So I really try to steer away from any judgy type questions. So I never ask that, but it's the only major thing that's changed, that our numbers are down so much. A lot of those people had things that probably would have been ruled out weren't bad emergencies, but some of those people are having heart attacks, they are having strokes, they are having appendicitis, or they're significantly suicidal, or they are at the point where they want to finally break down and get help with their substance abuse. So they all don't have bad outcomes, but I'm sure there are some bad outcomes that will come from putting off an ER visit if people think they want it.
Now, I know that especially when it comes to COVID, and of course, if you're experiencing symptoms, you're suggested to come in, call your primary, or, to come in and get treated. I guess from an ER perspective, if somebody is having minor symptoms of COVID and they don't want to go right away to the ER or, to the doctor to get treated, what are some things that you would recommend if that's something they don't want to do right now that they could do at home? And when is the time to possibly get care for COVID symptoms?
That is a superb question. And for that person who has one of the myriad of symptoms that we worry about COVID, specifically fever, body aches, cough, fatigue, loss of sense or smell, or vomiting or diarrhea. Those are all things that we've seen consistent with COVID infections. Now, there is no treatment for COVID. There is absolutely no treatment for COVID. It runs its course. We can support people through that illness. So really if you're having those symptoms, there's really no need for intervention except for home care. Take cough medication, take Tylenol, Advil, take it easy and keep away from people. However, for a diagnosis, let's say you're having these symptoms, and what I told people a month ago when we had very few tests, if you're having these symptoms, assume you have COVID. And what you do then is you quarantine yourself, you stay away from everyone, stay away from family members, and don't go out until those symptoms are gone for at least 72 hours. Now, the tricky part of that is there's two caveats with that. When we didn't have testing a month ago, who knows where COVID is? We don't have the diagnosis. What's our numbers? We don't know. We're not testing. We're finally getting some tests. Not the amount I would like, but there is testing availability. So there's two things. If you're having the symptoms you want to be tested, there's a couple things you can do. Number one, you can call your primary care physician. They can put an order in, and there are a myriad of drive-up places. So you can just drive, put a swab up your nose, and drive away and get the results that way. In fact, I think I'm not a primary care physician, but I think that's how the primary care physicians are wanting it, because they're trying to keep people quarantined or keep people social distance. We are the same way kind of in the ER. We are doing some testing in the ER, which that just started. Up till about a week ago, we only had enough tests for our admitted patients. So people were coming in requesting testing, and I was telling everybody, you probably have COVID, go home, and if you want to test, this is how you do it. So I would say that is still the primary way to do it. Things that to worry about for emergencies when you need treatment for COVID. How COVID kills people is basically wipes out their lungs. And what's really frustrating is there's nothing really to do except for support that. And how we're doing that is simply, if people are in distress, we're putting them there on their belly, laying on their stomach. That helps with the ventilation perfusion mismatch and really helps with oxygenation. And it sounds really simple, but it works really nicely, because we learned in the first few months, the first few weeks, I was putting a tube down these people's lungs, intubating them all. They were all dying. We've learned that pronating people helps them much better. There have been, you may have heard of all the drugs that are possibilities. Dexamethasone is the most recent. We as caregivers are reading those studies coming out every day. None of them have been studied enough to know if they really work. There's no magic medication. We're using dexamethasone. We're using some plasma. Everything else, and remdesivir is a question also. So we're using some of those, but none have been proven to be the magic bullet to really help. So the symptom that you would really worry about and think, I need help, I need medical intervention right now, is specifically worsening shortness of breath. That's a reason to get your rear end in to be evaluated somewhere.
Great, thank you for that. I know that's, as far as for me too, that's really good information to know. And just because there are so many different things out there of what to look for when you're experiencing COVID symptoms and what to do. And of course, this is, from your perspective as an ER doctor, but I think too, since you are located in Milwaukee, I think what you did bring up too was calling your primary and of course getting direction from them as well. I think would be really important too in your areas that individuals are in. So I appreciate that perspective though coming from you. I think the next question I have, and I know that it was, and I'm not sure if it still is an issue, but as far as like PPE equipment within your emergency rooms, how have you guys managed to, get access to those? Or is there still a shortage out there for healthcare professionals? Is there anything how is that being addressed to make sure that your staff and people that are working in the ERs are also being safe?
I can just speak for my system, which is Ascension. I work within the Ascension system. We have never had a problem. We've never had shortages that I've noticed. That's the admin that does that. I know that they're dealing with that all the time. But from my perspective, I've always had access to N95 masks and gowns. So I feel, at least in my emergency departments, all I can tell you is that we are protected and we're good.
That's good. And I think the last question I have around COVID, so looking at, I guess even within, so the protocols of if somebody does come to the emergency room, what would somebody expect coming to one of the Ascension emergency rooms? So just walk us through that process. If somebody is coming in saying they have the symptoms, what's next then? And how do you guys treat that within?
For sure. So as you walk through the front doors of the emergency department, you're met by somebody and they say, are you having any of this symptoms? They'll go down the list. And everyone is handed a mask. Everyone once you're in the hospital, you're wearing a mask. If you screen positive for COVID symptoms, you are flagged. And so that I know and the nurse knows, everybody who comes in contact with you knows that we're going to be wearing full PPE when we see you. So you are evaluated and placed in the proper area. Now, many EDs, and we just changed this a day ago, there are no visitors, absolutely no visitors. As of yesterday, I believe we're screening and letting in some visitors under some situations. So that's another thing to be aware. Even support people, it's the patient is going in. And so once you're in a room, they'll close the door if you are screened positive, and you'll have a conversation. And if you are being tested, I don't know if any of you have had the test, but I'll describe it to you. The test that we use is a long Q-tip. It's on a Q-tip at the end of a long metallic rod, or sometimes it's plastic, but it goes in your nose. And as I explained to it, it feels like we're going into your brain. We're not. We're going into the nasopharynx, so we're going all the way in the back of the nose, all the way back here to the back of your throat. So it's uncomfortable, makes your eyes water, makes you want to sneeze and cough, and people don't like it very much, but it's very important we get all the way back here to get an adequate sample. That stays in place for about 10 seconds, then we gently kind of roll it as it comes back out. And that's the test that's done. Usually we will test people's pulse oximeter, make sure that their oxygenation is adequate. And depending on symptoms, sometimes we'll do a chest x-ray if it's specifically COVID. Obviously other symptoms will look at other things, but if it's somebody, I'm just thinking COVID and they're looking pretty good, basically what I'm doing is evaluating them, listening to them, looking how they're feeling. If they're looking okay, I'm just doing the test and sending them home. And then the turnaround time for tests has been about 4 or 5 days. So I've been telling people, you've got possible symptoms, go home, quarantine yourself, and we'll call you with the results.
And are you guys, within your emergency room, have you guys been able to get enough testing for individuals that are coming in the emergency room?
We have, and that's new. Initially, we had a limited amount of tests. So initially, we were just testing hospitalized patients so we could know where to put those patients in the hospital. In the last 2 weeks, we had increased tests. I've been told in times that we're running low, but I've never been told since we started testing people who are discharging home, I've not been told we can't. The turnaround time has changed. Sometimes they're doing them different places, so it depends on where it's being tested, how long it's going to take. But the quickest it turns around is 4 to 5 hours. But I usually tell people 4 to 5 days because that's the longest it'll happen. So I usually try to under promise and over deliver if possible.
Great. What I'd like to do is open any COVID related questions up to individuals that are here in the live with us right now. Or even if there's some people on our staff here that want to ask Julie some questions, I'll open it up here for a couple minutes. Maybe nobody has questions.
If nobody has any questions, I would love to touch on something Jessica talked about right before we came on. And that was simply the question, what are we supposed to be doing now? We're getting such mixed messages. Should we open up? Shouldn't we open up? What should I be doing? Is it gone now? And again, this is me speaking as an ER physician, not an epidemiologist, but somebody who's been reading extensively about this. You need to do what you want to keep yourself safe. So when the virus became apparent to us in March, the call went out to social. What that meant to do was to decrease the amount of hospitalized patients. The virus is still there. We are nowhere near to herd immunity. I think, and it's hard to tell because we don't have good antibody testing, but the closest approximation across the country is that we have about 10% people who are immune right now. And so we do not have herd immunity. We do not have a vaccine. So we are all at the exact same chance of getting this infection that we were in March. That has not changed at all. What the social distancing did was try to stagger those people getting sick so we didn't overwhelm our hospital system. So when you go out into the world, you still need to wear masks. You still need to social distance. You still you need to, anytime you have interaction with people outside of your pod, I like to call my family my pod, you need to know you're putting yourself at risk to contract the virus. That has not changed from day one. So the virus is still there. It's still exactly as virulent as it was previously. But the fact that we're opening slowly is just to keep the world going. It doesn't mean the virus has changed. We still can get sick with it, but in order to get the world going, the government is allowing things to open up slowly. And we're seeing spikes, which is what we knew would happen. That's an expected outcome of opening. And the hope is that it doesn't get so bad that it overwhelms our hospital. We are not seeing that. We are seeing spikes, but right now, at least the hospitals I'm involved in, and I'm on webinars almost every day across the country. New York, Detroit, Florida are being a little bit overwhelmed right now, but at least in our little Milwaukee County and within Milwaukee and Dane County also, we are not overwhelmed. Is that a good enough explanation of that, Jessica? Because I did think there's a lot of fear out there, and there should be, but also we have to know that this is a infection with about a 3% mortality rate. Again, we're not sure if that is right because we don't have all the testing, but the vast majority of people get sick and not have significant death or debilitation. However, the reason to not get sick also is to not make anybody else sick. So that's my best answer right now. Again, I'm not an epidemiologist. I'm just Julie, the ER doc.
I think we should say you're Julie, the ER doc, not only the ER doc. No, I think that was a good explanation. I think now that you're talking a little bit about this, I have another question, I guess, for maybe this is a question that other people have too, but I feel like every other day I'm hearing come fall, there's going to be another huge spike of the virus, and I know that as far as for me being a parent and and having a kid in school, our schools are trying to figure out what that's going to look like in the fall, and all these fall activities that we're looking forward to, are things going to be canceled because of this anticipated spike. Is that something from your perspective? Is there any truth to that? Is that something that could happen in regards to how this virus is when it comes to changing of the seasons and the flu season?
The virus, the first test we have with this virus was seasonal, was summer coming, and the summer did not affect this virus at all. So the only thing that I would see with flu season is that we would have the addition of people with influenza with this. So that would increase our numbers. I think in the fall, especially with kids going back to school, we'll probably see another surge. And again, that's just because we're going to be open, we're going to be exposed to each other, and that's again expected. The more we're together, and I don't think we're going to have a vaccine, at least Fauci just said maybe by the end of 2020. Who knows? But it won't be before then. We will not have a vaccine before school. So I'm assuming we're going to have another surge. And again, that's expected, completely expected.
Great, thank you, Julie. Anybody else have any questions? I know we're a few minutes away from our end here with Julie, but I just want to make sure anybody that has questions around this topic has the chance to ask. So I'll just open it up here quick. It looks like Sandy may be asking a question.
Yes, I was wondering if you still refer to 30-day programs for people with substance use disorder?
We do. We are still making all the same referrals. However, and this is again, there's so many different places. Some places want COVID testing before we do that, but yes, all the same. We are still going through all the same places we did when people are seeking treatment that we did before. We're finding that once we make contact with those places, they may need us to do other things, but yes, totally still referring the same way we did pre-COVID.
Thank you.
And I guess since we're on the topic too of individuals, I know that you're a part of the ED2 program. Have there been any, I guess for that program specific, and I know that you mentioned earlier too, as far as individuals coming into the emergency room because of overdose or substance use disorder, that has decreased a little bit. How has that been affected because of COVID? Could you talk a little bit more about how potential overdoses have been handled throughout the last couple months, and the level of overdoses that have possibly changed?
We've been handling overdoses exactly the same way as we did pre-COVID. The only thing that's changed in my world is that our recovery coaches were phone consults during the COVID. However, as of this morning today's Wednesday at 6 a.m., our recovery coaches are now coming in person to talk to them. I think in the first week or so of COVID, there was a little bit of rush to get people out of the ER initially, because I think that first week of COVID, when we were all kind of crazy, the docs were a little crazy too. They just wanted people out because they were worried about them getting something in the ER. And I think that's the only blip I might have seen where people didn't get as good as referrals as they did, because I think that the people were just thinking, oh my gosh, we have cooties here, get them the heck out. So in that week, we might have had a little blip, but right now everybody's treated exactly the same. And I've seen, sounds horrible, I have a little bit more time to actually sit down and sometimes you have to lead people to the discussion. I think a couple more minutes with talking to somebody can get important information out that can start another conversation. With my decreased census, at least personally, I have a little more time to sit and weed out some of these problems. People might not come out in their first 5 minutes of conversation, may come out in the 6th minute that I now have to sit and talk with them. So it's been good in that way.
Yeah, and I guess too, I know that you've been a part of the ED2 program since October in 2018. For those that may not know about the ED2 program that are on this call or watching, maybe just talk a little bit about your experience with that program, and even a little bit about, what it is from the ER's perspective and how it's benefited individuals that have come into the ER.
I could talk about that all day. I love it. The reason we felt that we need the ED2 recovery program was because we were completely inadequate in referring people out of our ER to get help. In October 2018, I would give people a piece of paper. Sorry, you've got substance abuse problems. Here's your piece of paper. Follow up as an outpatient. We were woefully inadequate. Our social workers were great, but we have spotty social work. They're there for 8 hours. Some of them are interested in substance, some were not. So that's why I was very excited about the ED2 recovery program. So now when somebody is identified as having substance use disorder, and we define that as any substance use, even alcohol, we make a call, and a recovery coach comes physically to the ER within an hour. So this is especially helpful in people who have just overdosed, and we've brought them back with naloxone. Sometimes, not all the time, sometimes that's a little bit of a come to Jesus moment, and we feel people are more apt to talk to somebody. If I find in talking to somebody that they've got a list of opiates a mile long and they're mixed with benzos, and I've identified this as a problem, sometimes that moment has people will want to talk about it. I can't talk about it. I don't have lived experience. I don't have the time. I'm not smart enough, and I don't have the right language. So what the recovery coaches have given us is that person who can say, where are you in your recovery process? I will meet you there and see what I can do with you, and I will help you navigate through. It has been life-giving to the patients and to recovery coaches and to our staff, because it has been people come in crisis to the ER, and we were missing a huge opportunity to reach out our hand to them and say, we are here for you, and we can actually give you help. I think prior to that, I would be saying, hey, I'm here for you, but I got nothing to offer you. Now the recovery coaches can help them navigate that path that I don't understand to get recovery. From that, it's kind of exciting. I just got off another meeting an hour ago. We are also initiating buprenorphine in the ER and putting together a B team so that we have a bunch of us on call. So if we find somebody who actually wants to start buprenorphine and is in the right spot to do that, we will come in and evaluate the patient with the recovery coaches to make sure that we have follow-up and induce them in the ER or in the hospital. This is for inpatient, and it's also for OB. Induce them in the ER, induce them where they are, and then I'm going to give them a prescription for a week, and then set them up to follow up with buprenorphine. So that's been exciting. That's all come out of the ED2 recovery. That's because of all the conversations we've had, and it's snowballing. And what I really love about this also is I'm embarrassed to say, when this all came up 2 years ago, I had some of my partners who are reticent to prescribe naloxone because they thought it was supporting opiate use. I mean, that's what I was starting with my group, with some of my partners. Those partners are the ones now who are getting X-waved and are so excited about it, and it's done wonders for everything we've done in the opiate community. It's been wonderful. So we appreciate ED2 recovery a lot.
Well, that's amazing, especially the last part that you talked about, because I know that even the prescribing of that within the ED, I know it's with my communication and conversations in the past with you, that was something that you always had passion about, because of the MAT and where that's come in the process of recovery and being accepted, as a means of treatment and a pathway that somebody may choose. So I think that's really cool that it's finally starting to get lifted off the ground there with you guys. I'm excited to hear that. So I think that's amazing. I also want to, if there's anybody that has any questions related to the ED2 program or anything that we've talked about today, now's the time. We've got a couple minutes here for maybe 1 or 2 questions for Julie. So if anybody has a question, feel free to chime in.
If no one else has a question, I do have one for you, Julie. So right before we came on, we were talking a little bit about the ED2 recovery program and racial disparities and kind of what's been going on in our nation, and with, you know, the state of Wisconsin right now. And I asked you, working in Milwaukee and with people of color in our ED2 recovery program and people who've come into the emergency departments, I kind of wanted to know what that was like. And I think a lot of organizations choose to not speak out regarding, you know, recent events regarding the murder of George Floyd. And maybe it's because we worry that, you know, we'll say something wrong, or we're going to be misunderstood, or maybe we'll offend someone. I think Wisconsin Voices, we really want to engage in community leadership, and the idea that leadership starts with responsibility. And so when looking at Wisconsin, historically, Black communities, as a nation as a whole, Black communities have been, and they continue to be, impacted by addiction and the overdose crisis. But yet the treatment and recovery supports are not accessible to many Black and Brown communities. And so I was just wondering what you're seeing down there and what you think we could do to eliminate health inequalities, maybe in your area, but also statewide. I know it was a mouthful, but I absolutely adore you, and I know that you speak the truth, and so I just kind of wanted your feedback.
You are exactly right. And part of the systemic racism that's been part of our world has culminated at St. Joe's, which is the hospital that I work at primarily. It's my favorite place, and it's in a very challenged area. And if you look at it, we were looking at it this morning. When you look at treatment programs, they are all around Milwaukee, but 53206, 53210, my zip codes, none. So part of our push right now, and we just applied for a grant from DHS, is to get treatment programs there at St. Joe's. And that's one of the reasons why, Wes, when we first started working, when we first got this grant, my primary focus was Joe's. So many of these innovative things, pilot programs, are all done at the hospitals that we can make a buck out of. My focus is Joe's. Everything we've done, my first time to do it is going to be at Joe's, because that's a community that gets overlooked most of the time. So I'm always trying to start all of our stuff right there. And my next push is really with Hope, the recovery coaches that we're working under, trying to get recovery coaches from that community, because that's one of the paucities that I've seen. We do not, at least that I've met, we have no recovery coaches who are Black. We need to do that. And this goes, I could talk about this for a long time too, because oftentimes people will say that's not a Black problem, it's across the board. Well, the reason that again, this is my theory, historically, physicians didn't prescribe as many opiates to people who were Black, and I think that may be why there's not a spike with that, because of the racial injustices were done previous. Maybe it's shown that they don't have an inordinate amount of opiate use disorder in the Black community. It's even across the board, but that may just be because of the prescribing practices, historic prescribing practice. But that's all theory. That's just me talking out my rear end. But I hear you, Jessica, and I feel it every day, and that's why I'm trying to start everything in that area and let it grow from there.
Great, thank you, Julie. Is there anybody else that has any questions for Dr. Julie today? If not, we will let Julie be on her way. We appreciate all the work that you've been doing, Julie, especially, not only during the COVID, but, especially during this time of, the ED2 program that you've been implementing within your hospital, and the support that you've given people in recovery. and specifically in the area there in Milwaukee, because we know that the need is everywhere. But since working with you in the past, that is an area that sees a huge number of individuals that need this service, and we see it on this end. Specifically, like you were talking at St. Joe's, we see the number of individuals that have come in that you guys have been able to help, and that's so appreciated from us and from everybody, and even specifically the people that are getting the service and the help from you guys there. So we appreciate it. Thank you for coming on today. I'm sure we will be in contact soon for some things coming down the line here that we could potentially work on together. So we're excited about that. But other than that, I hope everybody takes care. Thanks for all the great information from you, Dr. Julie, on COVID-related topics and questions. For those that continue to tune in here every week, I'm not sure if we do, maybe Jessica, you could answer if we do have somebody on Friday. If you can go back and look at our Facebook page, but if we do, it will be posted there. If not, tune in next Wednesday too. We'll be having another guest. But like I said, everybody be safe during this time and stay connected. So with that, we will talk to everybody later.